And hello and welcome along. Hi, this is Kathy Frey from IMCO, from the International Integrated Maternity Healthcare Organisation. And welcome along this week to Dr. Julia Bartrop. And Julia, say a big hello.
Hi.
Julia has been a little bit of a regular for us on here, and so I think that rather than me going over your full bio, why don't you do that today and just give your own little reintroduction before we go into this topic today of recurrent miscarriages. And actually, we here at IMCO have asked Julia to specifically talk on this topic because for those of you who may be familiar with our Ask the Maternity Gurus forum, this is just something that comes up recurrently, and it's just one of those things that women find out incredibly early that they're pregnant. They're then very emotionally invested in that pregnancy, and it may have been even before the egg is implanted. So yeah, welcome along, Julia. And I know you've got a most amazing PowerPoint that you're going to present today.
Thank you. Hi, everyone. I'm Dr. Julia Bartrop. So I am a Chinese medicine practitioner. I also have 16 years of working in pathology. So I've got a Bachelor of Science in Medical Science. So I guess what I do is I combine my Western knowledge and my Eastern knowledge and put it together so that everyone gets a holistic overview when they come to see me. And I guess what I want to say is with medical tests or Western tests, the doctors can say, yep, everything's great. So there's being great and there's being ideal and there's being where I want you. So everybody's different, and different reference ranges will be different for different people depending on what's going on. So this is how I work. It's like we'll have a Chinese medicine diagnosis, and I will go and get people to go and have the blood tests, because without having the blood tests, I don't know what I'm doing. I'm treating blind. So it's really important that if you're a practitioner or if you come to me, I do telehealth sessions as well, that if I ask you to go and get tests, it's really important that you go get the tests, because there's a reason that I'm asking my clients to go and get the tests. Because all of this helps me to put together my way of treating and making sure that the man and the woman is in the best health to conceive a child. So
yeah, I'll just interject there and just support you on that comment, that there's, what Western medicine might say, oh, that's normal range, and then there's actually an optimal thing, and they can be so different, which I know you're going to go through here today. But yeah, that's sort of probably the real underscoring of all of this, of really IMCO, is that healthcare is holistic and it's a whole picture scenario. And it's not just a case of looking at one thing, which unfortunately our allopathic or Western medicine will also often do. It will look at a very isolated piece of information and go, that's normal, without looking at the whole big picture. So this is hopefully going to be, I know it's going to be a very enlightening session, because if there's one thing Julia really knows, it's this topic. So I'm going to turn off my screen and turn off my microphone so that I'm not, there's no interference there, and I'll be listening intently.
Oh, let's see if we can get this going. Oh, I don't know what that is there. Oh, that's not the window I want. Can you see that now, Kathy, or not? No. There we are. Slideshow on. Can't see with everything up the top.
Oh, if you could click on the little button just down the bottom. for the, oh yeah, just getting it to the full screen of the slides. That's it, perfect.
We've gone back. There we go. Went to the end. It's always the way, isn't it? Technology is great. Okay, everyone. So I'm going to talk today about recurrent miscarriage. So this is becoming more and more prevalent in today's society. However, women can test a lot earlier than what our grandmothers could. So our grandmothers didn't necessarily know that they were pregnant until their period was 2 or 3 weeks late, maybe even 4 weeks late. Whereas now, with all the pregnancy tests that you can do, you can get a positive pregnancy test 7 days, you know, when basically the egg has just implanted. So it's even more prevalent now, because back when I first started in the lab, if people wanted to know if they were pregnant, we did the pee on the stick. So they do their pee sample and we'd do it, and we'd also do the blood test to confirm that they're pregnant. So the golden standard for confirming that you're pregnant is the blood HCG, not just a positive pregnancy test. We want to establish that there has been implantation, that that embryo has implanted and is producing HCG, and we want that HCG to be rising and doubling every day, basically, to establish a pregnancy. So I'm also going to put in chemical pregnancies into recurrent pregnancy loss, and this also comes into autoimmune factors now. I've been doing a bit more research into this. So for instance, I have had one client, she had 6 chemical pregnancies, had a natural first pregnancy, and nothing went untoward. And then she had 6 chemical pregnancies, all natural, no issues getting pregnant, but she was having issues maintaining that pregnancy and losing the pregnancy at around 5 weeks. So for that first week that she was pregnant, she'd have continuous spotting, which to me indicates, okay, something is not right as well, which is exactly what she felt. Chemical pregnancies, it is a pregnancy. An egg has been fertilized, so therefore we do have an embryo. It's just that that egg may have implanted but has not actually attached and gone on to produce a viable pregnancy. So this is becoming more and more prevalent as well, and the research at the moment with the chemical pregnancies is that there could be an autoimmune factor going on, so you would need to apply your autoimmune protocols for that. Okay, so recurrent pregnancy loss or recurrent miscarriage is now defined as 2 or more pregnancy losses. So I am putting chemical pregnancies into this. Statistically, it affects less than 5% of couples, but I am finding that more and more couples are experiencing this issue. And again, I think this is also because women are finding out they're pregnant so much earlier as well. So literally they're just on 4 weeks and they're finding out they're pregnant. It does increase with maternal age and parental age. So this goes for both the male and the female as well, and is prevalent for older males who may be having their first child or trying to have children with a second partner. It's clinically recognised in 12 to 15% of pregnancies. And for those in unrecognised pregnancies, it's about 40 to 50%. So when we are trying to conceive, the chance that we have per month is actually about 12.5% of conceiving every month for every woman. So as we age as well, that chance actually decreases to about 5%. So for those women who are 40 and over, you're looking at about even less than 5%, that's at about 2%. So, but for women who are under 40, 35 to 40, it's about 5%. For those that are less than 35, you're looking at about 12.5%. And I've just put in a list here that you can click on about the statistics of recurrent pregnancy loss. So you can just go and have a look at that in your own time. Okay, so the causes of recurrent pregnancy loss. So there is a huge range. 50 to 75% is unknown. So this just might be that the egg and sperm weren't viable together. There may be genetic issues. There may have been too much too many chromosomal issues. So the egg is really good. It can actually change and adapt to the constituents if there are abnormalities, but it can only do so much. So if there's too many abnormalities or genetic abnormalities, or it's just not viable, then the body won't accept it as a pregnancy. You can also have anatomical issues. So these can include fibroids. You could have Asherman's issues, adenomyosis, and incompetent cervix. So I have had one client, we had 5 miscarriages. She did have a miscarriage at 15 weeks, and then she'd had 5 miscarriages in between very early. And then this pregnancy, we actually got her to 26 weeks, but she did have an incompetent cervix, and that cervix started opening at 14 weeks. So with Chinese medicine and bed rest, we actually got her through to 26 weeks this time. So endocrine issues. So these can be thyroid issues, they can be hormonal issues. So hormonal imbalances is huge in recurrent pregnancy loss. So not enough progesterone being produced. Diabetes is another one. The immune system. So this is the huge one. When it comes to recurrent pregnancy loss, and there's a lot more research being done. So there's a lot more issues with the DK alpha gene. So this DK alpha gene is where the male and female have very, very similar genetics. And the way of treating that is that they have, they're put on steroids for the whole pregnancy, and they may need intralipid injections too. So this is done under specialist care. The MTHFR gene, so this is where if you can have a heterozygous MTHFR gene or a homozygous. So homozygous is 2 of the same, the heterozygous is 1 of one and 1 of another. So with this, you can't actually process folic acid correctly, and it turns folic acid into methylfolate, and this doesn't get absorbed by the body. Instead, it just goes round and round and round in the body and forms a toxin. And this can impede a pregnancy as well. So it's really important for people that have the MTHFR gene not to be taking folic acid. They need to be on 5-methylfolate or folinic acid. So natural killer cells. So we all have natural killer cells in our body. And our natural killer cells are there to kill invaders in our body, viruses and bacteria. So we do naturally have natural killer cells within our uterine lining. Now, there's lots of controversy over natural killer cells at the moment, in that they don't necessarily behave the same way in the uterine lining as they do in the body. However, if you do have natural killer cells, you tend to have recurrent miscarriages sort of very early. Or you've had a normal pregnancy but are having continual miscarriages after having a pregnancy. So natural killer cells need to be investigated by a biopsy. So a biopsy is the gold standard for natural killer cells. And if you have more than 14 per field in your uterine lining, they say that your natural killer cells, you're NK positive. So there is protocol that we use with acupuncture and herbs and reducing inflammation in the body. And they also need to be under specialist care, and they will be generally put on prednisolone and clexane. They may have an intralipid infusion prior to an embryo transfer. Most of these clients are generally going through IVF, although I've spoken to another couple of acupuncturists and practitioners, and they've actually got a few of their clients pregnant without IVF naturally with the natural killer cells, just doing our Chinese medicine with them. And then autoimmune conditions. So I've just had another client. She's had 12 miscarriages. She's been going through IVF. The longest that we've got her to is 14 weeks. And she's actually, we did a whole heap of tests, couldn't find anything, was referred to a hematologist who's now found antibodies present in her body. So she's now going through a protocol to treat those antibodies and treat the autoimmune condition before she has another embryo transfer, to make sure that everything's good with that. So with autoimmune conditions, we do have protocols, and that does involve changing diet, reducing inflammation, making sure that we've got them on herbs as well. So chromosomal abnormalities, so this is where we're thinking about genetic abnormalities, and this can be caused through DNA fragmentation, or as we age, the eggs and the sperm are not as genetically good as when we're younger. So this can be due to the baby or the parents, and generally if there are chromosomal abnormalities, the body will deem that embryo as non-viable and will expel it. So environmental issues. So when we're talking about environmental issues, this can be due to body weight, alcohol, diet, etc. So environmental issues are generally not as prevalent as your anatomical issues, endocrine issues, immune system, and chromosomal abnormalities, but they do play a part in recurrent pregnancy loss. So your anatomical issues affect 15 to 20% of women who are having recurrent miscarriages. These can be there from birth. So if you're looking at anatomical issues, it may be that there's a fallopian tube missing, or they're not born with an ovary. Some women have 2 uteruses, or their uteruses may be bicornate or a different shape that may impact a pregnancy. Or it can be acquired. So this could be endometriosis or adenomyosis or Asherman's syndrome, where they've got scar tissue through that uterine lining as well. Fibroids are a major impactor, as is cervical incompetence. And then you've got your scar tissue adhesions, polyps. So if someone's got PCOS as well, or if they've got numerous ovarian cysts, that can also impact. So most of these anatomical issues can be helped with surgery, and they can be investigated through a hysteroscopy, which is where they actually put dye in through the tubes, and then they can see if there are any anatomical issues, such as issues with the ovaries or cysts or blockages in the fallopian tubes, or absences of these in the body as well. So endocrine issues. So we're looking at diabetes. So diabetes is an issue. Especially uncontrolled diabetes, because your blood sugar levels are too much, the insulin's not balanced, and that actually impacts your reproductive function, and also impacts the quality of the eggs as well. So thyroid can be clinical and subclinical. It's really important when we're treating fertility that both the male and female have their thyroid checked. And even if they come back, a lot of the blood tests now, they'll only do thyroid stimulating hormone. We want the full panel. You need to do thyroid stimulating hormone, T3, T4, and reverse T3, plus thyroid antibodies. Because although TSH can be normal, there can still be things going on with the thyroid. And if the thyroid's not functioning properly, this impacts on fertility and pregnancy as well. So the other thing is low progesterone. So you want your clients to be doing a BBT chart. So this is basal body temperature charting. And from the basal body temperature chart, you can get an overview of how their cycle is. You know, if there is a luteal insufficiency or a short luteal phase, then you generally know that progesterone and prolactin are going to be an issue, and hormones are out of balance. So although you can go and get them tested, you can have a look and it can come back fine. I always like to rely on the BBT chart, because this gives me the most information about what is going on in a woman's body and how her cycle is functioning and how her hormones are actually functioning as well. So from a BBT, you can see whether a woman is ovulating or not. You can see whether her body is trying to ovulate. You can see where they've drunk alcohol. You can see where they've had a bad night's sleep. You can see how stress affects them as well. And stress is a major factor in trying to conceive, but also with pregnancy loss as well. And then you can have the corpus luteum insufficiency, which is that prolactin. So once we've actually ovulated, that corpus luteum is left behind. So that's the actual outside of the egg. So when the egg is growing or the follicle's growing, this provides all the nutrients to the follicle. Once that follicle has been ovulated, the corpus luteum is left behind, and this actually secretes the progesterone and the prolactin, which if a embryo is fertilized and implants, this is responsible for producing that progesterone and the prolactin until week 12, when the placenta starts taking over. Okay, so chromosomal abnormalities. So these can be a genetic abnormality with the baby. It can be chromosomal abnormalities with similarities, such as the DQ alpha gene. So this is where your genetic genes are too similar and the body won't enable a pregnancy because the genes are too similar. So these people have to go and have specialized treatment, and they will be under a highly specialized doctor. And generally what they're doing is they're having intralipids and steroids, and they'll be taking steroid injections all throughout the pregnancy as well. So DNA fragmentation of sperm can also affect the chromosomes here. So if there is a lot of DNA fragmentation, and we generally see this in older males, but also it is prevalent in younger males. And the research is now stating that because of the mum's use of plastics back in the 80s, this is also affecting sperm and also affecting the DNA fragmentation of the genes in the sperm head as well. So old eggs and sperm, as we get older, the quality of the eggs and sperm is not as good as it might be when we're 15. So this causes an increased chance in the chromosomal issues. So spontaneous miscarriage, if there are chromosomal issues or there's too many chromosomes or the body deems it as not viable, there will be a spontaneous miscarriage. And this is generally where we have a look at chemical pregnancies as well. And this is also where testing really early, because the woman knows that she's pregnant. I don't recommend, I wait until they have a missed period. Generally, so that will be about 5 weeks. If we are going to have a spontaneous miscarriage, it's generally between as soon as the egg is fertilized and fails to implant. So it's generally that 4 to 5 weeks that you will get a quite quick spontaneous miscarriage. Otherwise, if it is viable with life, you might get it later, so about 16, 20 weeks, or if it's such a twin-to-twin transfusion syndrome, you might find it much later in the pregnancy as well. And so you can have a look at these investigations for chromosomal issues through karyotyping. So this is genetic testing of the fetal material. So if your client does have recurrent pregnancy loss, and if they are able to save that pregnancy material, please make sure that they get it tested, because this way we know whether it was due to chromosomal issues or whether, if everything's fine with the chromosomal, with the chromosomes, we need to do further investigations. So the immune response. So this is huge, and this has become more and more prevalent in the last 5 years. So the major ones that I am seeing is natural killer cells and the DK alpha gene. So as I mentioned, natural killer cells are your natural white cells in your body as part of your immune system. We have them there so that if a virus or a bacteria or a fungi or anything gets into the body, they're there, they're sent out by the body. They're the ones with your weapons that go pew, 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 and kill the invading organism. So what they think, and this is not, this is the process of what they think natural killer cells are doing in the uterus at the moment. You do have natural killer cells naturally in your lining. However, it should be less than 14 per field. And how they actually diagnose natural killer cells is they need to take a blood test, but the golden standard is a biopsy. So they will actually go in and take a biopsy of the uterine lining, and then they will stain it, and they will have a look under the microscope, and they will count how many cells there are within that piece of tissue. Now, if you've got over 14 cells within the lining, then they'll generally say that you're natural killer cell positive. And they will start the protocol for natural killer cells. So this is an immune response, and basically those natural killer cells will attack the embryo and prevent a pregnancy from continuing. So the DK alpha gene is where two people who, you know, you can be on different sides of the earth, but somewhere way back there's a lineage that they share and their genes are too similar. And so the body goes, no, this is not viable, and we'll try and not allow a pregnancy to happen. So autoimmune response, so we're also seeing this after COVID as well. So there's been a lot more fertility issues with COVID, and the autoimmune response basically says, yep, no, we're not allowing a pregnancy. And then we've got the MTHFR gene, which is where they have problems absorbing folic acid or methylating that folic acid or breaking down a synthetic form of folic acid into the folinic acid. And then this just builds up in the body and goes round and round and round and becomes really toxic. And this can also affect pregnancies. Okay, so clotting is actually really huge as well. So if you are having someone who's experiencing recurrent miscarriages, you want to have a look for clotting factors. So this may, or they may be aware that they've already got a clotting issue, such as thrombophilia or factor V Leiden. And this can cause clots through the placenta and can lead to miscarriages later on, or they may not even know that they have it and they'll end up miscarrying sort of around 20 weeks. So this is done with a clotting factor panel. So, and this will also run through lots of different clotting factors. So it will do thrombophilia, factor V Leiden, and then you've got a whole heap of other clotting factors and cascades that can affect pregnancies as well. So as said, it may cause clots in the placenta, or it may cause clots in the maternal blood, which in chance will block blood flow through to the baby and lead to miscarriage. Or there may be a mother-baby incompatibility due to the clotting factors, or this could also be part of anti-D if the baby is anti-D positive and mum is D rhesus negative, and they may not have had the injection after a previous pregnancy, or if she's had recurrent pregnancy losses previously and she hasn't had the injection, this can also lead to a pregnancy loss. So other causes, and generally if women are going to IVF, they will be checked for these infections prior to even starting, but we need to have a look for UTIs. We also need to have a look for cyclomegalovirus, rubella, chlamydia, and peritonitis. And then acute or chronic maternal infections. So this could also be even an overgrowth of candida or thrush or bacterial vaginosis, which is Gardnerella infection, or they may have other viral or bacterial infections that they may have had when they were a teenager that are still lingering. So we need to make sure that these are all checked and cleared and that there's nothing there. So these are not a high prevalence, but you just need to rule them out and make sure that there is no infection, because that can be a cause of recurrent pregnancy loss as well. So environmental causes, so this can be increased body mass index, alcohol, drug use, too much caffeine, an older first age of pregnancy. So we're looking at women who may be 40 with their first pregnancy. So these are all linked, but they're not diagnostic of a recurrent pregnancy loss, but they do play a factor. So if you've got someone who's not necessarily fit, who's 40, who's overweight, who may be in a highly stressful job, these are all, so they end up stacking on top of one another. So this is how we tie in environmental issues to other issues that may lead to recurrent pregnancy loss. So investigations. So this is really important, especially if someone's had 2 to 3 miscarriages in a row. So you want your chromosomes checked, and this is done by karyotyping and also ultrasound. Your clotting factors, so you'd be wanting to order a clotting factor panel. So anyone who's had a miscarriage around 4 to 6 weeks or within that 4 to 8 weeks, especially if it's even twice in a row, I'm automatically referring them for a clotting factor panel and doing miscarriage blood tests straight away. I don't want them having another one and being mentally, physically and emotionally affected, and it does affect everyone on all levels. Some women it affects greatly, other women are like, yep, okay, let's just get on with it and do what we need to do. But yeah, if someone's had two losses in a row, even if they're really early, I'm straight onto miscarriage bloods. And that's really important to do. And just let them know why you're doing it and that we're doing this because I want to rule out all of this and make sure that everything's great before we try again. So thyroid, again, we went through, there might be hyperthyroid, there might be antibodies, it might be subclinical hyperthyroid. So if you've got a woman in front of you and she is having trouble losing weight she has cold hands and feet, she's eating really well, she's exercising, but she can't lose weight, you would be thinking her thyroid's not functioning, and you'd want to go and get her thyroid tested. And like I said, you can't just rely on the TSH, which is thyroid stimulating hormone. You want to get that T3, T4, reverse T3 and antibodies tested, because they may have Hashimoto's, they may have Graves' disease, which if they do, that's autoimmune, and we need to put in the autoimmune protocol to treat them. So your immune system, so you need specialized investigations, so genetic testing of both parents. So this is for the DQ alpha gene and also the MTHFR gene. So your natural killer cells, so again, this is if someone's having recurrent pregnancy losses really early, like within that 4 to 8 weeks. So I would also be thinking sperm issues in that 4 to 8 weeks, but I'm also highly alert for natural killer cells. And this can also be the cause of chemical pregnancy. So basically you are getting a fertilization of the egg, an embryo has formed, however, it's not implanting and sticking properly. So hormones, so you want to make sure that the male hormone and the female, their hormones are balanced and there's no insufficiencies there. So I would get a sperm test for the male, but I'd also be measuring his testosterone, his sex hormone binding globulin, his estrogen, his progesterone, all of his hormones. We want to make sure that everything is functioning there as well. For women, we're looking at follicular stimulating hormone and estrogen, progesterone, prolactin, luteinizing hormone, and estradiol as well. So we can also do ultrasound. So this is more if we're thinking that there are issues with structure. So this is where we do the hysteroscopy. And then again, you do the sperm test, a DNA fragmentation test and sperm antibodies. So a lot of people will investigate the female, but they forget about the male. But the male is also contributing 50% of, the sperm to the egg. And it's really important that we don't leave the male out, because in recent times, at the moment, the cause of infertility at the moment with males is 50%. So, and about 10% of not being able to get pregnant is put in the idiopathic category, and they're now saying that female infertility is now reaching about 40%. So the male infertility issue is actually taking over females now, and it's really important that we look at both partners. Okay, so assistant. So generally a miscarriage is a spontaneous loss of a pregnancy before 20 weeks, and early miscarriages is a loss of a fetus prior to 12 weeks. So these can be due to the genetics, the chromosomal issues, hormonal insufficiencies. So this is where low progesterone comes in. So if progesterone is low, what they will now do is they will either give them progesterone pessaries, or they'll give them progesterone cream, and they will be using those up until week 14 of the pregnancy, just to establish the pregnancy and make sure that that placenta is up and running. And once the placenta is up and running, they will then take them off the progesterone pessaries or cream. So late miscarriage occurs after 12 weeks to 24 weeks. Now, we can have miscarriages from 15 weeks and over due to an incompetent cervix. Again, that hormonal insufficiency. So if they've taken off progesterone, but the placenta is not actually producing the progesterone, this can cause a miscarriage as well. So the infections, this is why it's really important that we get them tested for UTIs, for a bacterial infection, viral infection, the CMV, any infections in that pelvic area, or an immune reaction. So this is where your NK cells come in, your DQ alpha gene, and your autoimmune conditions such as diabetes, thyroid issues, and celiac disease is also a really prevalent one as well if you're not eating correctly for it. Okay, so basically for environmental factors, if their BMI is too big, we're looking that we want to decrease their body weight and body fat. Basically what I say is go and do some yoga, go and do some Pilates, go and do some walking. I don't want them to be in the gym for an hour, but we want them to be exercising more. So if that means that they stand in front of the TV and walk while they're watching a TV show, that's great. They're moving. This is what I want. We do say for all people trying to conceive, please avoid alcohol. Decrease your caffeine. So for those of my clients that are trying to get pregnant, we allow them one really good coffee a week. If they're taking drugs, please have them stop taking the drugs. Marijuana does affect pregnancy. And if you're on any other heavier drugs, yeah, it's definitely going to affect your pregnancy. So again, improve their nutrition. I always run through what they're eating. We want to improve their nutrition. We want lots of fresh veg, fresh fruit. If they can't do that, they need to be definitely on a multivitamin, especially for preconception. I'll also get them on fish oil and CoQ10. They may need alpha lipoic acid. This is where supplements come in. So it's really important that we're getting nutrition. And also before trying to conceive, that we've got them on good nutrition, which is going to increase the sperm health and improve egg quality at the same time. And I'm treating both partners. Even if one partner won't come in and see me for acupuncture, I'll at least get them trying to do the supplements, or at least get them on a multivitamin. And I will be big on giving them herbs as well. Okay, so assistance for recurrent pregnancy loss. So hormonal insufficiency. So I will know if someone's hormones are not functioning through their BBT chart, and we will make sure that we are treating and balancing the hormones. So it may be that they need the bioidentical hormones, so the progesterone cream and press series, as I previously said. To balance the hormones, we'll be using herbs, we'll be using acupuncture, also nutrition and supplements as well. If they have had numerous recurrency pregnancy losses and it's due to hormonal insufficiency, you want to make sure they're not over-exercising, they're not on their feet too much, and they're getting bed rest. Again, progesterone is given for the first 14 weeks until the placenta is stable and is producing progesterone itself. So you need to monitor them, so they may adjust the dose of the progesterone as well, and they'll be having weekly blood tests generally, so they'll make sure that the progesterone is staying high. And again, I help assist with hormonal insufficiencies with acupuncture, Chinese herbal medicine, and again, your supplements. So your immune factors. So these are the ones that I've spoken quite a bit about. It is immunotherapy that they need to be treated by, and this is highly specialized. So it will either be through the IVF doctor or an immunotherapist as well. So it needs to be done under specialist care. I can't treat DQ, alpha gene, or I can't give intralipids or anything like that. It has to be done by a specialist. So with the MTHFR, as I've said, no folic acid. So if any of your ladies are taking a multivitamin that has folic acid in it, you need to tell them to throw it in the bin. I don't care how much money they're losing. It's not good for them. It's toxic for them, and it's affecting their body. It goes straight in the bin. You want them to be taking a 5-methylfolate, or that it needs to have folinic acid in it, or you get your folate from your food. So your natural folates come from your dark green leafy vegetables, and this is actually the best source of folate. However, you need to make sure that within their pregnancy multivitamin, it has 5-methylfolate or folinic acid in it. If it says folic acid anywhere, it gets thrown in the bin. I can't push that enough. So clotting factors, if there are clotting issues, you want them to be on aspirin or baby aspirin. Some women may be on heparin, and they will need to be having an INR or warfarin. They'll need to have their blood tested regularly to make sure that the levels are good. If there are thyroid issues, you want to make sure that their iodine levels are good. And if it is subclinical thyroid, you want them to be making sure that they are getting iodine in their body, and that we're giving them foods that will help to support thyroid as well. A specialist will give them thyroxine as well. So it's just a matter of monitoring the dose, because once we are pregnant, our body does produce more TSH as well, and your TSH will go up. So this really needs to be monitored during pregnancy. But low thyroid is a cause of pregnancy loss. So it's really important that we do treat the thyroid. So supplements. So if they do have autoimmune issues, if thyroid isn't functioning properly, or we've had recurrent pregnancy loss, Ubiquinol, okay, so this helps with egg function as well. CoQ10 also helps with sperm function. So CoQ10 is really important for both male and female. Melatonin helps with sleep, but also improving egg quality. Alpha lipoic acid also helps to produce antioxidants in the body and helps to improve egg and sperm quality. You want them on a good quality fish oil. If they're vegan, you can put them on algae oil. You want them to have low toxicity throughout the house. So BPA, bisphenol, has been linked also to recurrent pregnancy loss and affecting fertility. And a lot of the IVF clinics will actually have it in their leaflet saying, please go through and make sure that you remove all BPA from your house. So what I suggest, if people find this too much, start with your kitchen. So go through all your cleaning products and just make sure that it's all BPA free. You can bring in essential oils for cleaning, like bicarb soda with lemon juice is really good, non-toxic. And that's really good. And then you want to have a look at your drinking container, because that can have BPA in it as well. So we suggest going to glass. Have a look at your makeup. Makeup also has BPA, as does your deodorants and your body washes. So you want to try and make sure that you're BPA free as much as you can. The other thing is N-acetylcysteine, L-acetylarginine, and myo-inositol. So myo-inositol I use for my PCOS clients. And this actually helps with the insulin, especially insulin-dependent PCOS, and this helps balance the sugar levels as well. So you can use this with diabetes, or they might be on metformin as well. So, and as I've said, just go through the house and remove your BPA and all your old plastic containers, and make sure that you're as BPA as you can, BPA free as you can. So we also put in, so anyone who's got autoimmune conditions, we'll put them on the autoimmune diet, which is a form of a paleo diet, or the Mediterranean diet as well. Both of those diets are really good and are high in nutrition, but you're also balancing out your protein, your carbohydrate, and your fats. And they also help to improve the quality of sperm and the egg at the same time. So Chinese medicine and TCM has a really important role to play. It's extremely good to go through acupuncture and Chinese herbal medicine with the Western medicine as well. I combine these together. So it's great for threatened miscarriages, habitual miscarriages, and hormonal insufficiencies. So we can get the body back into balance before getting you to try again for another pregnancy. And for cervical incompetence, we actually have a formula which we use called Hold. And as I said, my last client, we weren't aware that it was cervical incompetence until week 15 this time. We caught it early. She was on bed rest. I was giving her the Hold formula, and we got her through to 26 weeks. So it's also really good to aid with recovery after a loss. So we're looking at the whole person. So we're helping them to recover physically, mentally, and emotionally before maybe trying again, if they're ready to try again. And everyone will have different times and different ways of grieving as well. So we are just allowing their body to heal, and we're allowing them a safe space to grieve and to process what they need to do. So in terms of if there is recurrent pregnancy loss, if there are autoimmune conditions, if there are hormonal insufficiencies, if there are clotting factors, we can use our acupuncture and our Chinese herbal medicine to basically rebalance their body and to bring them back into balance, which will increase the sperm quality and the egg quality, as well as also assisting with their mental, emotional, and physical health. As I said, with the cervical incompetency, if there is a stitch and they're on bed rest, we can assist with aiding baby to stay put by using our herbal medicine alongside Western medicine as well. So basically in Chinese medicine, we look at recurrent pregnancy loss as a form of kidney deficiency or essence deficiency. So there's not enough vital essence in our body to give enough nutrition and enough energy to actually carrying a baby at the same time. So if you have a look at kidney yang deficiency, cold hands, feet internally feeling cold, this relates to hypothyroidism. So they're cold, they're having issues losing weight. This affects fertility. Blood deficiency, not enough blood to make a period lining or carry a baby. So this can be related to anemia, iron deficiency, also not having enough blood to form that lining. Again, we're looking at boosting up blood. We're looking at boosting up their nutrition. A lot of women who may be iron deficient as well, this is where iron transfusions come in. They may not have enough time to build up blood. If their ferritin is really low, I will suggest that they go off and have an iron transfusion. This helps the body to actually produce a better lining. So if in some instances it's because there's not enough blood, that we're losing the baby really early, the iron transfusions can help, and we'll also keep them on blood building formulas for the entire pregnancy as well. So if they're really weak, we see this as a Qi and blood deficiency. They can't hold the baby, there's not enough energy and there's not enough blood. So again, if this is the case and we've done all the Western medicine tests, clotting factors, etc., and nothing comes back, I would be telling people to hold off. We need 3 months to basically build you up, to fertilize the soil, to nourish the soil, and to build up the body. And then we might look at trying again. I'll get them to go back and I'll keep them BBT charting so that we can see how the hormones and everything are going. And the BBT chart also tells me how my treatment is going, as well as how their home works. So reducing stress, exercising, reducing caffeine is working as well. So diet's really important. So a lot of my females, I'll put them on the anti-inflammatory diet or the autoimmune protocol diet or the Mediterranean diet, just because this is one of the healthiest forms of diet and helps to improve egg quality as well as overall health and wellness. So Chinese medicine for recurrent pregnancy loss, we're coming at it using herbs and acupuncture. So we're boosting them up on all levels. So we can assist with balancing hormone imbalances. We can improve egg and sperm quality. We can improve the endometrial lining, especially for those with endometriosis or adenomyosis. We can improve emotional issues and trauma. We can aid with how stress, depression, trauma, grief affect the body, and also how cervical incompetency affects the body by using the acupuncture and using the herbs as well to try and hold baby in there while they're on bed rest. So using Chinese medicine, we're enabling the client to heal at their own pace as well as improving overall health, and it's extremely powerful. So I am constantly amazed with our medicine. I never know what our medicine is going to do, but it's been used for so long and it is just really, really powerful, and the amount of change that you can get is just astounding. Again, we work alongside IVF and specialists. We're there to support them. Quite often, a lot of my clients just come in going, I've so been looking forward to my appointment and coming to a safe space and just being able to chat. Sometimes, you know, fertility is your natural state. You just may need to tweak the body just to wake it up. We just may need a bit more nutrition. We just may need to calm them down. They just may be in a completely heightened stressed state, and that's impacting their body from holding a pregnancy. We're looking to decrease stress and anxiety, and we want to balance those hormones, so that HPO access. And also some people, I found, they may not be getting pregnant because they've blocked themselves off due to previous losses. So we need to have a look at that heart and kidney connection. So, and sometimes it can just be a matter of reestablishing this connection, and that allows that cascade of hormones to actually come into balance and allows the body to grieve or to process what they've been through, and then we can have a pregnancy and maintain a pregnancy. So the experience of pregnancy loss is both physically and emotionally draining. And TCM has the ability just to allow people to grieve and to process and to heal at their own pace, at their own time, while providing a calming and soothing and supportive environment. So just in conclusion, recurrent pregnancy loss is defined as 2 or more pregnancy losses. It used to be 3, it's now 2. It affects less than 5% of couples. It does increase with parental age, and it's extremely high after 45. It doesn't have to be consecutive. So they may have had a pregnancy loss and then a live birth and then 2 pregnancy losses and a live birth. There's many causes. 50 to 70% of what causes a recurrent pregnancy loss is unknown. And that we use Chinese medicine alongside Western medicine just to treat the body holistically, and to rebalance and improve a person's health. And just to remember that fertility is your natural state. And sometimes, yeah, we just need to tweak the body and allow people to heal at their own pace. And that's it.
Oh, that is so good. Gosh, isn't Julia just the most amazing? You're like an encyclopedia of knowledge. It's just awesome. And so thank you for presenting on this topic, and the fact that we've asked you specifically to talk on this topic, because it's just been one that just keeps coming through, obviously, recurrently. Hey, just a few little questions I've got, which others may have. What's your thoughts with regards to women who are on antidepressants, SSRIs, etc., anti-anxiety medication, already, you know, before or while they're trying to conceive? Do you sort of, I know it's a general comment, but you know, there is that feeling of like, you need to get off the drugs that you're on, but then of course those are, or you know, that's a different kettle of fish, because we're talking of emotions and it takes a long time to wean off them. And so where's your sort of advice around that, because it's so prevalent that women are on some form of SSRI, etc.?
So with that, it depends. I have had some women who have worked with their psychologist or their psychiatrist for 6 months trying to get pregnant, to wean them off or find different ones that may not be as toxic to a pregnancy as what they were previously on. If they've been on it for a while, we will work with psychologists or psychiatrists to see if we can reduce the dose. However, if they're absolutely needing it, then I'm like, that's fine, just stay on it, and we will work with them, because we don't want them coming off it and then not functioning either. That's not what we're about.
Exactly.
So we're
in terms of a rock and a hard place. Do you find sometimes, you know, I know that this certainly is seen a lot in geriatric patients, where they have been on prescription medicine for so long, and nobody's really questioned it. I remember speaking with a friend of ours who runs a retirement village, where this woman had been on an antidepressant for 25 years. And she was questioning, you know, how come? And she was like, well, it was when my husband died, they put me on it, and they've kept her on it for 25 years. And, you know, like, I mean, sometimes depression is clearly event related, you know, something occurred and now you've moved on. But sometimes I feel like women, for humans, and not just women, but we can see it as a crutch that is very hard to let go of, when actually you are ready to let go of it if you know that there's another way, there's something else, you know. Do you ever sort of go down the track of things like Siberian ginseng or 5-HTP, or, you know, other ways to sort of come off the pharmaceutical drugs and onto the, because obviously in that whole journey of pregnancy, there's so much anxiety that could be coming in. You know, it's far less anxious to be not pregnant than to be pregnant or being a mother.
So if someone has a history of depression and anxiety, and they're wanting to become pregnant, we will talk to them, and I will recommend that they go and talk to their psychologist or their psychiatrist about maybe different options and what they can and can't use during pregnancy, so that they are highly aware of what their options are. In terms of people, if it is chemical and they can't come off it, we also have herbs that we use for anxiety as well, which I will give them, which they take 2 hours away from their Western medication. So we can still give them extra herbs as well as having them on their antidepressants or their anti-anxiety drugs. And for those that do want to come off them, then I suggest that we work with them for 6 months prior to actually getting pregnant so that we can wean them off or lower the doses with Western medicine, and we will use our Chinese herbal medicine and acupuncture as well. So yes, we do use Siberian ginseng in a lot of our formulas, but we don't just, it's really important when we're doing our herbal formulas, they're all combined. So we have like a chief herb and a guide herb and, you know, the adjuvant herbs, which all come in, and they're all going to different channels. So they all work together. It's not just that we give them one herb to treat this. We're looking at everything holistically and supporting the whole entire body, so emotionally and physically and mentally at the same time.
So great. And just to know that there's basically other options.
Yeah.
And where you mentioned melatonin
Mm-hmm.
in there, that's obviously it's not an easy thing to be able to actually buy as a member of the public.
No, so I would, you would need to talk to your healthcare practitioner about melatonin. I don't give melatonin out to everybody, but it is one of the supplements that I can use. And melatonin in general, you can't just buy over the counter either.
Right, exactly. And what else have I got on my list? I know that you've spoken about this before on other webinars, but would you like to just go over again your view, your holistic views on what are great iron levels? Because iron depletion anemia is so common in pregnancy, and I personally as a midwife have a real bugbear of when women are having their very first iron level check, at the end of their second trimester. I'm like, that's crazy. We need to know this right at the beginning, and in your case before the beginning, before conception, because I mean generally, they say anything over 20 is normal range, and if it's less than 12, if it's under 20, that's iron depletion. If it's under 12, that's anemia, but I know that you have holistically a way different view on that.
So generally I'll be looking at ferritin, but I'll also be looking at their hemoglobin. So a lot of people will say, oh, my hemoglobin's fine. So if your hemoglobin is right down the bottom of the reference range, I'm going, you're already iron deficient. So we need to boost you up. You're already blood deficient, you're already iron deficient. So
especially going into a pregnancy.
Especially going into a pregnancy.
Because by the time you get to your third trimester, you've got 1.5 times normal blood circulating in your body. Your body needs to be able to have fantastic levels to be able to produce all this extra blood. Yeah.
So I like the ferritin to be at 120. So if ferritin is less than 120, I'm like, it's too low. If someone comes in and ferritin's at 20, I'm like, you're not getting pregnant the next 6 months. We've got to build it up.
And to put that into perspective, because when I was a case loading midwife, would always get everybody's ferritin stores checked at the beginning of their pregnancy. And I would say that maybe 1 in 40 women is at that level.
They're not.
Yeah, right. And that's the thing is, there's most women, the majority are far below that level.
And this is
probably normal range.
So this is where I hate the normal range, because I had a lady come in to me and I'm like, I'd like your iron levels looked at. I think you're anemic. I think you're iron deficient anemic. And in Chinese medicine, you're blood deficient. She came in, her ferritin, I think, was at 12, and the lower reference range was 15, and her hemoglobin was low, her red cell count was low, her mean cell volume was low, and I'm like, you're iron deficient anemic, and her doctor said she was fine. And I said, you need an iron transfusion. I'm like, if you want to get pregnant quickly, you need an iron transfusion. So, and for those women that are coming in that are really low in iron, if we get them on an iron transfusion quite quickly, it gives their body that extra blood, that extra oomph that they need to help get them pregnant. And then throughout their whole entire pregnancy, I will have them on iron supplements, and I will be giving them blood building herbs throughout their entire pregnancy.
And those iron supplements.
And iron supplements throughout their entire pregnancy.
Yeah, they'll be supplements that don't have unpleasant side effects.
Yeah.
Right? Because that's a rubbish iron if they do.
Yeah. So I prefer to get your iron through the diet. However, I am finding a lot of vegetarians and vegans were having issues with getting their blood up. Liver capsules are great. If you can't eat liver, you can take liver capsules. Liver capsules are really high in iron. You can take them through pregnancy. I know it says caution through pregnancy, but if someone's really blood deficient and really low in iron, I will get them taking liver capsules as well, or even cooking the liver, which is what our grandparents used to do. They used to eat liver all the time. It's like, it's so high in iron, and it's really good for you. So, so if you can't stomach it, liver capsules are really good. So for those that can't have fish oil, I get them on algae oil for your omega-3, 6s and 9s, which you can get in nuts and avocado as well. But if they're really low, then I'll put them on algae oil as well. So, but iron deficiency is really, really prevalent. And a lot of women over here in New South Wales are blood deficient, iron deficient. And I'm finding that so many women, especially in their 3rd trimester, are now needing iron infusions. And the reason that I want your iron levels up is because when you're breastfeeding, from a Chinese medicine point of view, and even from Western medicine, it's basically you are donating blood every time you breastfeed. You are donating yourself for donating blood, giving it to another person. So we need you to have that stores there, and we need you to be built up so that when it comes to breastfeeding in the postnatal period, you've got enough blood, you've got enough energy, you've got enough there to produce breast milk. So, and this is also where I'm finding that a lot of breastfeeding issues are coming from, because women just don't have the stores. They're just so depleted before they even get to the postnatal period.
Well, thank you so much, Julia. You can unshare, I guess, the screen, but you're just such an encyclopedia. As I say, it's always such a joy to have you here. And for those of you that don't realize, Julia is also one of the very valued, dedicated volunteers at IMCO, and she's got we've got probably about half a dozen now, I guess, webinars that we would have done on various specific topics, but nearly always around fertility, that sort of whole general topic, right? But yeah, and things like preconception, healthcare, etc. So don't hesitate to go through the IMCO past webinar page, and you'll see a bunch of them there. But your webinars are always incredibly thorough and incredibly informative. So thank you. And those that are live here today with us, we always love our live audience. And I know that there's quite a few people who are always watching these later down the track as well. So just want to wish everybody a wonderful rest of their day and rest of their week. And thank you so much, Julia, for putting that time into presenting that with us. Thank you so much.
You're welcome. Bye.
Bye, everybody.